Well, I'm very pleased to get to introduce our program today. Dr. Matt Hendrich was born in Little Rock, Arkansas, and lived there until the age of 4. His family then moved to Valona, Arkansas, and he graduated from Valona High School in 1999 and went on to graduate with honors from Harding University with a degree in biology. He attended medical school at UAMS in Little Rock, choosing surgery as his career path early in medical school. He obtained a general surgery training at UAMS and followed with a vascular surgery fellowship for an additional 2 years at UAMS. When he was a senior medical student, he met his wife, the former Lindsay Jones, and they've been married now for 7 years. Lindsay was born here in Jonesboro at St. Bernard's and was raised in the small community of Clover Bend, where she still helps her father with the busy farm and a hunting lodge. So you may have figured out who his father-in-law is. As he neared the completion of his fellowship, he and Lindsay began considering a move home to Northeast Arkansas, wanting to be a part of the community where he could make a difference and provide a service that would otherwise be unavailable, and we're so pleased that he chose to join St. Bernard's Heart and Vascular. He and Lindsay are the parents of 2 children, Luke David, who is 20 months old, and Catherine Blake, who is 6 months old. Please help me in a Rotary welcome for Dr. Matt Hendrich.
Can everyone hear me well? Is it on? Well, I thank y'all for the opportunity to speak this afternoon. It's an honor and a privilege to come talk to each of y'all. What I'd like to do today is talk a little bit about the specialty that I've invested so many years to be a part of. I'd like to talk about the service that we can provide and what we can do for the community. So vascular surgery as a specialty is a relatively young specialty. In 1947, the SVS, the Society for Vascular Surgery, was founded, and one of their primary purposes was to encourage hospitals to develop special training for young surgeons in the field of vascular surgery. It wasn't until the late 70s and the early 80s, with the help of Dr. Wiley, that there were actually vascular programs put into place. By 1982, there were 52 vascular programs that were approved, and at that time they offered a special qualification in vascular surgery. Prior to this, there was no formal training or no accreditation for vascular surgery. The majority of vascular surgery was done by cardiothoracic surgeons, general surgeons, and at that time, or prior to this time, there were just only apprenticeships. You would essentially find out about someone who was doing a lot of peripheral vascular work, and you would go spend time with them, but no formal training. In 2005, the American Board of Surgery approved vascular surgery as a distinct specialty of surgery. And now there are 116 vascular training programs in the United States. However, there are still a very limited amount of graduates, as the majority of these programs only graduate 1 or 2 individuals annually. So today I'd like to talk about a wide scope of what we do as a vascular surgeon. I'm going to break this down into cerebral vascular disease, peripheral arterial disease, mesenteric and renal artery disease, aneurysmal disease, end-stage renal disease, and venous disease. So first, in looking at cerebral vascular disease, we commonly treat the carotid artery. It is by far the most common affected with regards to cerebral vascular disease. There is a predilection to form plaque right in the bifurcation of the carotid disease. In addition, the vertebral artery can also be affected. It arises off of the subclavian, which feeds the arm, and goes up to feed the back half of the brain. It also is affected, but not near as much as the carotid. So risk factors for developing cerebral vascular disease: smoking, high blood pressure, high cholesterol, diabetes, family history. These vessels are also prone to trauma. The neck is easily exposed. We can see penetrating trauma or blunt trauma to these arteries. Cerebral vascular disease is the second leading cause of stroke and transient ischemic attacks, with 800,000 people annually suffering from one of these events, which gives a lifetime risk of 25%. Once again, this is predominantly from the carotid artery. So the diagnosis can be made on physical exam by listening with a stethoscope over the artery. As the artery becomes stenotic, it has very turbulent blood flow. We call that a bruit. It can be heard very easily with a stethoscope. We typically then screen with ultrasound. This is an excellent screening tool. It gives us a good idea if there is plaque, how much plaque, and how severe it can be. But we very often confirm with CT angiogram. It is a little more sensitive, a little more specific than ultrasound, and also is very useful for surgical planning to really let us know that the disease is in a portion of the carotid that is amenable to surgery. MRI is also useful, but not as commonly used. Now, conventional arteriography is where we go in the femoral artery with a catheter and shoot dye directly into these arteries. We typically reserve that for tiebreaker, if you will. If there's discordant results between the ultrasound and the CT, we may perform arteriography. Also, other people may have metal in their body that make CT angiography very unreliable with a lot of artifact. That would be an option where we would go to conventional arteriography. So with regards to treatment, not everyone with carotid blockage really needs to undergo surgery. A lot of these people can be managed appropriately medically, and when we say medically, we mean an antiplatelet, either aspirin or Plavix, with high cholesterol medicine, Zocor, Lipitor, any of the statins, antihypertensives, glucose control, and then smoking cessation. Smoking really does drive the blockage in a lot of individuals. Now, we only manage it surgically if it's symptomatic and greater than 50% blocked, or if it is asymptomatic, meaning it's silent, but 70% blocked. That's when we manage it. Other than that, medical management is the appropriate treatment. When we talk about surgery, the vast majority of surgery performed for carotids is endarterectomy. This is where the artery is isolated and controlled and physically opened, and the plaque is taken out under direct vision, and then the artery is closed back. This is by far the way the majority of these are treated. Now, there is a role for stenting. It is typically reserved for patients that are high-risk patients, patients that won't tolerate anesthesia well, or patients who have area of the blockage in a place that is not ideal for open surgery, or for people who have a hostile neck, meaning someone who has previously had surgery in the neck or has previously had radiation. Now, when we talk about bypass for cerebral vascular disease, this is most commonly seen in the vertebral artery. We deal with those with small bypasses, or in the case where there is trauma or, God forbid, cancer. These two diagrams illustrate what I was talking about, where an incision is made along the neck, the carotid is exposed, it's physically open, the plaque is taken out, and then the artery is closed. This diagram illustrates stenting quite well, where a wire is used to cross the lesion, a balloon dilates the lesion, and a stent is left behind. Also of note, there's a small filter when we stent that we place in the artery to collect any kind of embolic debris that could be broken off in the process. Next, I'd like to move into peripheral artery disease. When we talk about peripheral artery disease, most of the time we're talking about the blood vessels that supply the lower extremities. I do want to illustrate that you can have blockage in the subclavian vessels, the brachial vessels that feed the arms. It's not near as common as the arterial disease for the lower extremities, but it certainly does show up from time to time and certainly requires treatment based on how symptomatic patients are. Very commonly affected would be the aorta, the major blood vessel in the abdomen, the iliacs, and the femoral arteries. These are very common places for people to develop blockage. In the diabetic patient, they tend to affect the smaller vessels down even further below the knees often. So risk factors, very similar to cerebral vascular disease. Smoking, however, I would really like to illustrate smoking. I would say 90% of the patients I see for peripheral arterial disease are smokers. Without question, it is a disease that is highly connected to the smoking population. High blood pressure, again, high cholesterol, diabetes, family history. Also, these arteries can be involved in trauma. The prevalence is pretty significant for peripheral artery disease. Actually, 10% of the aged 55 or greater population are thought to have peripheral artery disease. So next, I want to look at three kind of areas of peripheral vascular disease, three stages, if you will. You have claudication, rest pain, and limb loss. Claudication is pain typically in the calves at a reproducible distance. So a patient can say walk 75 yards, their calves hurt, they stop, the pain goes away. They can walk 75 more yards and the pain returns. That patient is not at risk for limb loss at that time, but can have debilitating symptoms that prevent them from working or other lifestyle. The progression then goes to rest pain. This would be pain in the foot itself when the patient is not walking. It's just pain all the time. And that really has shown a significant progression in the disease to where the foot actually does not have enough blood flow to be happy and is suffering from pain. Now, I don't want to confuse that with diabetic neuropathy, which is very common. That's a more burning pain, stabbing pain, where rest pain is a dull, achy, constant pain. And then as you progress down the severity of peripheral artery disease, you can develop ulcerations, ultimately leading to limb loss if not quickly addressed. So we diagnose this with physical exam. Oftentimes you can note a pulse discrepancy in the foot when you physically feel the arteries. Patients may have absence of hair on the legs. There can be coolness and discoloration, and certainly ulceration in later stages. We have a number of non-invasive studies that we perform where we actually measure blood pressures and correlate those to the blood pressures in the arm. We check blood pressures at different levels up and down the legs, looking for a drop in the blood pressure that would indicate having blockage above that point. We even check pressures in the toes and the fingers to help us diagnose this. Ultrasound does have some utility, but really CT angiography is the most useful in evaluating the exact location of the disease, and it also greatly aids in surgical planning. Conventional conventional angiography or arteriography also has a role. It allows you to simultaneously diagnose where the problem is and treat it if amenable to stenting. So with regards to treatment, like cerebral vascular disease, not everyone has to be treated. Medical management is appropriate for patients who do not have lifestyle-limiting peripheral arterial disease. And the medical management, again, is with antiplatelets, aspirin or Plavix, a hyperlipidemia medication, a high cholesterol medicine, an antihypertensive, glucose control, and then most importantly of all these is really smoking cessation and a walking program. Study after study after study shows that with smoking cessation and exercise, dependable exercise, patients will develop the ability to walk further without symptoms across the board. And so a lot of these people, if you can get them to halt their lifestyle, you can keep them out of a surgical intervention. Now, with regards to surgery, you can perform endarterectomy in the vessels that feed the lower extremities or the upper extremities also, and it's really utilized for focal plaque in a very defined location where you can get to it with one incision. Oftentimes that's not possible. The plaque, the disease involves a long segment of the artery, and then bypass is really the most appropriate option if it involves very, very long segments of the artery. Occasionally in people with atrial fibrillation, they can develop clot in the heart. That clot can be thrown out of the heart and can go into any blood vessel. That requires what we call either a thrombectomy or embolectomy, where the artery is open and that clot is directly taken out. We also have arterial lysis, where small catheters can be placed in the artery and a medication given that dissolves blood clots. It's essentially like a soaker hose that you put in your flower bed, and it dispenses medication evenly across the clot and can dissolve clot. That usually requires that clot be relatively young, but it can be very effective if the clot's only 2 or 3 weeks old. Then you have balloon angioplasty and then stenting. This is where we balloon the blockage out of the way, and if refractory to the ballooning, we can place stents to keep the blood vessel open. And then atherectomy is where a small catheter is placed in the artery that actually will chew the plaque up and pull the plaque out of the catheter. Some illustrations here again. Opening the artery requires control proximally and distally, opening the artery itself and removing the plaque, and then sewing the artery back closed. This illustrates a longer segment of disease that would most likely be appropriately managed with a bypass. Now, this is an illustration of a balloon inside the plaque, stretching the plaque out of the way, and then if refractory, a stent being placed to keep a scaffold in that artery, keeping it open. There are many atherectomy devices that work in many different ways. This is an illustration of an atherectomy device where it is taken through the plaque, chewing the plaque up, and then sucked out of the catheter. Next, I'd like to move into talking about mesenteric and renal artery disease. The mesenteric vessels feed the intestines. They feed either the small intestine, the large intestine, the liver, the spleen, and the renal arteries feed the kidneys. These are the arteries we're looking at here, the mesenteric vessels right here, all of these vessels that come directly off the aorta in the abdomen. So risk factors for developing disease here, the same as the other: smoking, high blood pressure, high cholesterol, diabetes, family history, certainly trauma. One thing with regards to epidemiology, females tend to have a higher predilection of developing mesenteric and renal artery disease. Also, with mesenteric and renal artery disease, you tend to be asymptomatic until you're well progressed into the course, and that's because of the elaborate God-given collateral network between all the blood vessels. So one blood vessel can be 100% occluded, but it has small side street connections to other blood vessels that essentially serve as bypasses within the abdomen. And oftentimes people can have 100% blockage and it doesn't need to be treated whatsoever because that patient is asymptomatic because of those God-given collaterals. Mesenteric disease can result in weight loss, severe abdominal pain, or chronic pain. We call it food fear. Patients will eat and absolutely have such debilitating pain after they eat that they just choose to not eat, and this results in profound weight loss over several months. Kidney disease or renal artery disease can result in kidney failure. The other important thing with mesenteric disease, if you see a patient with mesenteric disease, you have to be thinking there's other disease. 50% of those patients will have either cerebral vascular disease or peripheral arterial disease on top of their mesenteric disease. So diagnosis, we talked a little bit about this with history, the food fear, the abdominal pain, the weight loss. As the kidney arteries become significantly affected, it drives the blood pressure up substantially. So people with very uncontrolled high blood pressure that require 3 or 4 medications to control their blood pressure may in fact have a blockage in the kidney artery. That creates a scenario where the kidney secretes a chemical to increase the blood pressure because the kidney wants more blood. And so that can be what is driving the hypertension. And then late stages of renal artery disease, you get kidney failure. Ultrasound is useful, but less so because these are abdominal vessels. CT angiography, really the test of choice here. It defines the anatomy fantastically, also allows for operative planning. And then conventional arteriography has a little bigger role here because oftentimes patients come to you with renal dysfunction. And so you don't want to give a lot of contrast that can hurt the kidneys. So with conventional arteriography, we can decrease the doses of contrast by, say, 1/3 by directly injecting contrast at the artery. We don't have to use as much as required for a large CT scan. So treatment, medically again, if not significantly symptomatic, like in the case where I talked about having 100% occluded vessel but being asymptomatic because of the collaterals, we just treat these patients medically with antiplatelets, statins, antihypertensives, glucose, a very similar trend that you see across these disease processes. Now, surgical bypass has always been the mainstay for this, but that is a significant surgery. It requires opening the abdomen and typically requires bypass from the major aorta. It becomes a very big surgery. So we have certainly transitioned into angioplasty and stenting when the anatomy is appropriate and conducive for a stent in these areas. We now really offer surgical bypass for mesenteric vessels when stenting's not appropriate or if the stents have failed. Next, I'd like to talk about aneurysmal disease. An aneurysm is defined as a dilation of a blood vessel at when that blood vessel becomes 1.5 times the size of the normal blood vessel. The importance of an aneurysm is that it poses an increased risk of rupture of that artery. Also, aneurysms can thrombose, or they can collect blood clot that then gets embolized or distributed to other pieces of the body, and that's why we fix these. They can involve any blood vessel in the body, but very typically seen in the aorta, the popliteal artery, which is right behind the knee, and then the mesenteric vessels and the renal vessels are prone to have aneurysms also. So I'd like to single out abdominal aortic aneurysms because that's the most common aneurysm that we treat. So localized enlargement of the abdominal aorta, the major blood vessel that we illustrated on a previous diagram, and we start calling it an aneurysm when it's 3 centimeters. Now, risk factors for developing an aneurysm are age, male gender, high blood pressure, atherosclerosis, smoking, and family history. They really carry a strong family history. Significant chance that if a family member has an aneurysm, another person in that family will also have an aneurysm. So 1% of men, 55 to 65, have an abdominal aortic aneurysm. That's kind of scary. There's a male predilection here, 4-to-1 ratio, males versus females for abdominal aneurysms. And then results in 6,000 deaths per year where these aneurysms go undiagnosed and they just rupture. There's approximately 45,000 aneurysms, abdominal aortic aneurysms treated annually. Once again, we do this to prevent rupture mainly. So with regards to presentation, the scary thing is the majority of these are silent. They're just found incidentally. A person gets a CT scan for a renal stone, a kidney stone, or they get a CT scan for back problems or for some other vague complaint, and then they also find an aneurysm. And so a lot of these unfortunately go very silent until they become symptomatic or unfortunately rupture. If an aneurysm does rupture, it carries an 80% mortality with it when it ruptures. So with regards to treatment, we have very detailed guidelines with regards to abdominal aortic aneurysms. So we treat them if they're symptomatic. If the aneurysm is thought to be causing abdominal pain or back pain in any way, it gets treated. Otherwise, we treat these at 5.5 centimeters. And the reason for 5.5 centimeters is because that's when the morbidity and the mortality risk of surgery becomes less than the morbidity and the mortality associated with rupture. So an aneurysm less than 5.5 centimeters has a decreased chance of rupture and death versus if you operate on the patient. And so that's why we pick these numbers. Now in women have a smaller aorta, so a lot of us tend to kind of consider women for repair at 5 centimeters because their native aorta is smaller. Also, if an aneurysm grows, the number is 0.5 centimeter in 6 months. It's also meets the criteria for repair. Now, traditionally, we fix these open, but now we have endovascular means where we go in through the groin and we deploy big stents to fix these. I'd like to illustrate these here. Traditionally, we'd place a big clamp here in the proximal aspect of the aorta and then clamps down here and physically open the aneurysm and sew in what we call Dacron. It is a fabric graft to fix the aneurysms. And some people still require this today, but more often we fix these with what is called a endograft that is placed in through the groin and deployed. It's typically a modular graft having 2 or 3 pieces, and it allows a tube to be placed that shunts the blood through the tube, keeps the pressure out of the aneurysm itself. The morbidity and mortality is significantly less with this. The patients go home earlier. A couple days after procedure, you can go home to where traditional repair requires about a week in the hospital. So I'd like to move on to end-stage renal disease or kidney disease. This is a result of damage to the kidney. It makes the kidney unable to manage the body's fluid, unable to manage the body's electrolytes, or manage the breakdown products of metabolism. In the United States, it's mostly related to high blood pressure and diabetes. It can also be because of blockage in the artery, atherosclerosis, and it can be congenital. The reason why vascular surgeons are involved is because of the access for dialysis. So renal artery disease or end-stage renal disease affects 660,000 people annually, 660,000 people in the United States, 468,000 of which are currently being dialyzed. There's a male predominance. It's mostly a disease of the middle-aged population, and approximately 90,000 people die a year for complications either related to end-stage renal disease or related to dialysis. So my role in this as a vascular surgeon is the access. In order to have dialysis, you have to take a large volume of blood out of the body, has to be cleaned and given back to the body in a very efficient time frame and in a safe manner. And the preferred method is really an arterial venous fistula. And what a fistula is a connection between the artery and the vein, and it allows the vein to mature. It may dilate 3, 4, 5 times its normal diameter, and the flow goes up significantly. It could be even as much as 2 liters a minute going through that fistula. That allows the dialysis professionals to pull large volumes of blood off, clean that blood, and give it back safely. It's by far the preferred mode of dialysis. It increases life expectancy, decreases the morbidity and mortality associated with end-stage renal disease and dialysis, and very importantly, it decreases the health care cost by absolutely millions across the board to decrease risk of infection and readmissions. It's just better for the patients. Now, some people have very small veins and can't have a fistula, and then we would place a graft, which is a prosthetic conduit that serves the role for the fistula. Another way for dialysis is a temporary catheter or even some long-term catheters. However, those are not meant to be there forever. These are placed when a patient comes to the hospital and has to have dialysis essentially urgently, but they damage the vessels that they go through. So really not meant to be the mode of dialysis. Now, peritoneal dialysis is dialysis inside the abdomen. It requires a catheter where fluid is put in the abdomen and then drained back off. That's another effective mode of dialysis. This illustrates where we can make a little connection here at the wrist between the vein and the artery. We also do these up here at the arm crease. Once again, it allows the vein to grow substantially. The dialysis professionals will access the vein with needles and pull blood off, clean it in the system, put it back into the vein. This illustrates a graft in a patient that has very small veins. The graft is placed and is accessed directly for dialysis. The last topic I'd like to speak about is venous disease. It certainly does not get the attention that arterial disease gets in society, but the prevalence of venous disease is significantly more than arterial disease. And what we're really talking about here is venous thrombosis, varicose veins, and venous insufficiency. So DVTs are a condition where you form a clot in your vein. There's different things that can predispose you to get DVTs, but that clot can propagate and form a pulmonary embolus. And that's when we really start worrying about it, because that can be a lethal problem. When it breaks off, it goes to the lung. Most of the time, DVTs are managed with anticoagulation, but some people are significantly symptomatic. When the DVT or the thrombus involves what we call proximal veins, or the main veins that drain the legs, the big veins in the abdomen that are draining the legs, they can cause some severe debilitating swelling and pain and ulceration. And in those cases, we use the lysis technique, like I had spoke about earlier, to dissolve that clot, and we can even stent these blood clots. Now, varicose veins plague society. Many people have varicose veins. Anybody who's worked on concrete for years standing is going to develop varicose veins. It's a component of gravity fighting against the blood and the veins simply becoming large and dilating. Now, traditionally, we would strip those out surgically, but now we have small catheters that we can insert into those veins and burn the vein from the inside, scarring the vein down. Chronic venous insufficiency is really kind of the end result of horrible varicose veins or horrible venous thrombosis, and this is where the blood simply can't get out of the legs. The blood breaks down in the legs, hurts the skin, and causes ulceration in the skin. This catheter kind of illustrates, there's a number of catheters you can use, but this small catheter we now just place inside the varicose veins themselves. We heat those veins up from the inside, and the veins will scar down instead of having to go strip those veins out. This is a very well tolerated procedure. We do them right in the clinic. People don't have to have anesthesia for it. It's a huge, huge breakthrough in the way that we manage varicose veins. Very minimally invasive, same-day procedure. Well, that was a lot. Vascular surgery is a huge field, and I wanted to touch a little bit on everything to kind of give everybody an idea of what I do as a vascular surgeon. In conclusion, modern vascular surgery is really a relatively new specialty. It hasn't been out very long. It incorporates big, open, elaborate surgical procedures with new minimally invasive procedures, and also incorporates the ever-changing technology, all to provide really optimal treatment to the patients. It really requires that a surgeon be proficient in surgery, in radiology, in intervention, as well as vascular medicine. The disease burden of vascular surgery is growing as our population ages and our baby boomers. We're seeing more and more vascular disease. Unfortunately, we're not producing more and more vascular surgeons. We're still kind of at the same rate. And so it is becoming difficult to manage the burden in society. Vascular surgery is a very demanding career. It really takes a lot of attention and a lot of time, but I will say it is very rewarding. You have the opportunity to save lives and save limbs and make impacts on people that last a lifetime. And it's been a very rewarding career for me. Happy to have chosen to be a vascular surgeon, and happy to be here in Jonesboro and with St. Bernard's offering this service to Northeast Arkansas.